Hello, overcomers, and welcome to this episode of Connect Ovar Coffee, where we host candid conversations, make meaningful connections, and talk about all things and science of all things ovarian and gynecologic cancers. I'm Runsi, the founder of Overcome, and today I'm joined by a very special guest, Dr. Alexander Olawaiye. So Dr. Olawaiye is a member of the Sponsored Clinical Trials Partnership of the UPMC, and he is a world-renowned gynecologic oncologist. As a leading gynecologic oncologist and clinical trials investigator, his work focuses on advancing treatment options for ovarian cancer and bridging the science with compassionate and patient-centered care. So join us for the next hour or so as we talk to Dr. Olawaiye to dive into the discussion around innovation and new advances in ovarian cancer, including learning about his groundbreaking work with the much anticipated ROSELLA trial. So please, as I always say, please share this information far and wide with anyone who may benefit from all the wisdom he's about to share with us today. So with that, a huge welcome to you, Dr. Olawaiye, to this episode of Connect Ovar Coffee. Absolute honor to have you with us.
Thank you for that generous introduction. I'm honored to be here. Good evening, good morning, good afternoon, everybody.
Thank you. So as a new friend of Overcome, just to start us with, tell us a little bit about your background and what led you to focus your career on ovarian and gynecologic cancers in particular.
Thank you. That's a very important question because following leaving medical school, I was immediately got into residency in obstetrics and gynecology in the United Kingdom. And in the United Kingdom, there wasn't, during my time, a subspecialty training like in GYN oncology, like the one that you have in the United States. But those who were interested in gynecologic cancers had to look for a center where somebody had that as one of their interests. So I was privileged to train with some famous names in England who were focused on gynecologic cancers. One of the attendings I worked with was Professor Jonathan Lederman, who is a world-renowned medical oncologist who focuses on GYN oncology space. Now, in England back then, there were a few people, actually, if I remember, 3 of them, who were the most popular GYN oncologists. I mean, the people that anybody with GYN cancer would want to go to for surgery and to oversee their treatment. And these 3 doctors, I actually did work with 2 of them. And looking at their background, I discovered that they had one thing in common. All of them were educated in the United States. So that's how I said, well, if I would want to be like these gentlemen, I think I needed to go to where they trained. And that was how I basically applied to come to the United States and go over residency and then fellowship in GYN oncology. And the rest is history after that.
The rest is history. That's right. And thank you for taking that decision, because that decision is saving so many lives. So thank you. So just delving into a little bit about ovarian cancer. So from your perspective, what you think makes ovarian cancer such a uniquely challenging disease compared to other cancers?
Thank you. That's a very important question. Number one, we, as of the current time, have no established screening method for ovarian cancer, okay? And not only do we not have an established screening method for ovarian cancer, we also don't have an established method of diagnosing ovarian cancer early.
Yes.
And that is a big problem because this actually goes for any cancer, even the very deadliest of cancers, including pancreatic cancer, stomach cancer, those kind of cancers, even brain tumors. If you find these tumors early, the options are many, many more than when you find them in advanced stages. And the ability to not only do good work for the patient, even cure the cancers are very high, but we don't have a way of diagnosing ovarian cancer early. In fact, 75 to 80% of patients diagnosed with ovarian cancer are in stages 3 and 4 at the time of diagnosis. This is what makes ovarian cancer unique. It's just simply that fact that by the time they become obvious and diagnosed, the cancer is really in advanced stages.
Yes.
Something we're working on.
Yeah, thank you. So speaking of the ROSELLA trial, right? So what unmet need in ovarian cancer you saw that led to the development of the ROSELLA trial, and what distinguishes this trial from the prior trials in recurrent or platinum-resistant ovarian cancer?
Well, so that's a very important question. There are different ways of describing the cause of ovarian cancer. One of the most commonly used descriptions is the platinum refractory, platinum resistant, and platinum sensitive. Platinum refractory is when the cancer is progressing even during the first time it is being treated. Platinum resistant is when there were, initial treatment goes well, but within 6 months of the initial treatment, the cancer recurs or progresses. And platinum sensitive is when that type of event occurs after 6 months. Now, in order of how that relates to prognosis, the most serious of the three is platinum refractory. And the next most difficult to treat is platinum resistant. And the platinum sensitive group, they have more options and they are much easier to treat. And in that group is much, much easier to push back on the cancer. And so what the phase 2 trial of relacorilant, which we did, was decided to go for the first two categories that I mentioned, the platinum refractory and platinum resistant, to use this drug called relacorilant in those two groups and see if we were able to prolong the progression-free survival and actually overall survival. And surprisingly, in these two very difficult groups to treat, the trial was positive. We had a prolongation of the progression-free survival and with a very strong trend towards achieving overall survival benefit. And therefore, that encouraging result was what led to the development of ROSELLA trial.
Wonderful. So I'm just going to go a little deeper into the ROSELLA trial to understand the mechanism that is behind the ROSELLA, and then what are some of you talked about the refractory and the platinum resistant patients to benefit most from this trial. However, just to dig a little deeper into that, is this like for platinum resistant and refractory patients in all types of ovarian cancers that would, react positively to the trial? And what are the, known or unknown side effects, challenges, anything really that you would like to share about this particular trial?
Thank you. First of all, when we went to phase 3, when we decided to initiate the ROSELLA trial, the patients that were allowed to participate did not include the straightforward platinum refractory group. Okay. Now, I say that, but one of the things that I must also mention is that in clinical trials, remember I defined platinum refractory as those who progressed whilst being given the first-line treatment.
Yes.
Many clinical trials now define platinum refractory as not only people that progress during active therapy, they also define them as people that progress within a couple of months of stopping that primary treatment. In ROSELLA, we allow those people who had progressed within a couple of months that other people are defining as platinum refractory, even though in the strict definition that has been used as standard, they are in the platinum resistant group.
Right, right.
And so when we launched the trial, we focused on platinum resistant subgroup, but we allowed 1 up to 3 lines of prior therapy. Now, just to make that clear, the more lines people have for ovary cancer treatment, the more difficult it is for the cancer to be treated. Okay, so we allowed up to 3 lines, which is indicating heavily pretreated group. We also allowed people that had been exposed to PARP inhibitor therapy, and this is a particularly difficult to treat group. When people have been treated with PARP inhibitors and then they experience progression, the cancer tends to be very difficult to treat, i.e., the chemosensitivity is low. We allow them. And despite this heavily pretreated group, the people that have been exposed to PARP inhibitors, ROSELLA got the result that it got, which is one of the reasons why we were really excited about the trial outcome that we got on ROSELLA, which is a positive progression-free survival benefit and positive overall survival benefit. Now, in platinum-resistant ovarian cancer, before ROSELLA came out in June of 2025, and before this overall survival readout, which happened just a couple of weeks ago, there was only one previous trial that had achieved a positive overall survival in this group of patients. And it's called the MIRASOL trial, which looked at the drug mirvetuximab soravtansine. And so ROSELLA would be the second trial published that would achieve the same result as the MIRASOL trial, which is, again, very exciting. There's a third trial now that we think that has achieved the overall survival benefit as well. It's called the Keynote B96 trial. And so we're in exciting times. For many, many years, we've studied so many drugs in this platinum-resistant space because of how difficult they are to treat. And in the last less than 3 years, we now have 3 trials that have been able to achieve overall survival benefit in these very important patients.
So, Dr. Olawaiye, as I was listening to you, there were a couple of questions that were coming to my mind. One was, you mentioned that for the ROSELLA trial, you had patients who were previously treated with PARP inhibitors. So does that mean that these patients are carry the genetic mutations that, because typically from what I hear that PARP inhibitors, work better for patients who are, they carry the BRCA genes and such. So was there anything you saw there? And the second one was, you talked about its similarities with the MIRASOL, right? But from what I understand from the MIRASOL trial, they had to be folate alpha receptor positive, that population. What are the differences between that and the ROSELLA, from what I read on the ROSELLA trial, it seems like you don't even need any biomarkers to get into the ROSELLA trial. So help us understand the mechanics of it a little more.
So I'll take the first question first. The people that have been exposed to PARP inhibitors, so until recently, there were 3 PARP inhibitors on the market.
Yes.
And in the first-line treatment of ovary cancer, one of those PARP inhibitors was actually approved in all comers. So patients, regardless of whether they had HRD disease or HRP or they had BRCA mutation, they were allowed to be given that drug if it was the first time they were being treated with, PARP inhibitors or for ovarian cancer. The second one was also approved specifically first in people with BRCA mutation, whether it's germline or in tissue, being treated for the first time. But that same drug combined with another drug called bevacizumab was approved as well in the group of patients with HRD disease. So coming off the first treatment, for first time treatment of ovary cancer, a huge number of patients were exposed to PARP inhibitors during the first time, regardless of whether they had BRCA mutation or not, right? And so they got a PARP inhibitor. It was just a matter of which one.
Yeah.
Now, we found out that later on, if you are looking at the profile of these patients, when disease recurred or progressed, they were more difficult to treat than the PARP naive population, i.e. population who had come through and were having progression without exposure to PARP inhibitors. And so a lot of the time, what you're doing is scratching your head about what to do to help these patients who have been treated with PARP inhibitors who are now having disease recurrence or progression, because things like most standard of care treatments tend to be not effective.
Yeah.
And in fact, some trials excluded them from being recruited into those clinical trials for that reason. In ROSELLA, we did not exclude them. If they otherwise met the inclusion criteria, they were allowed to participate. And when we analyzed the result, in fact, some of the subgroup analysis did not only show that this group benefited from relacorilant treatment, they seemed to even benefit more than the patients that did not have exposure to PARP inhibitors, which was surprising for us to see and very exciting. Number 2, the second question is about, can you remind me?
Yeah, we were talking about, you were talking about the MIRASOL trial. So I was asking you that from what I understand, they have to be kind of folate receptor alpha positive to be able to get the MIRV, versus what I have read for ROSELLA. So what are the key differences between the MIRASOL and the ROSELLA trial? I was just trying to understand that.
Absolutely. And in fact, the MIRASOL, the mavetoximab soravtansine medication was approved not just people with folate receptor alpha positive ovarian cancer, it was approved in people with high level expression of folate receptor alpha. The patients, per the approval, must have 75% of the cells being positive for folate receptor alpha. And because that's the group that was studied, that's the group that benefited. Unfortunately, I think the percentage varies depending on which part of the United States you're based in. But in our area, I have not been lucky to get up to 30% of patients being positive for folate receptor alpha, not at high level. So those patients that are not positive cannot be given that drug. In ROSELLA, the relacorilant drug, it was used without biomarker selection.
Right.
We did not select for biomarkers. And if we're going to talk later about the mechanism of action, I don't want to jump the gun and go into it, but glucocorticoid receptor antagonism is what the relacorilant drug does, i.e., it gets its job done by blocking the receptor for steroid. Okay?
Yeah.
Now, that receptor is expressed by almost all ovarian cancers. And so there was no need for us to do biomarker selection. We also looked at some of our studies that we did before using the same drug, relacorilant. We found out that the progression-free survival that we got for patients treated with relacorilant in the phase 2 trial did not depend on glucocorticoid receptor expression. And therefore, again, everybody can benefit, which is another exciting fact about ROSELLA and the relacorilant drug.
100%. That means that the base of patients who could benefit from this therapy is a lot broader. It's a more number of patients that can benefit from this therapy, which is wonderful. And you wanted to talk about the mechanism of action behind ROSELLA. This would be a great place to have that discussion before I get into the other questions. So why don't you enlighten us and help us learn a little more about that?
Thank you. First of all, relacorilant, that's the name of the drug that we use in ROSELLA. And the trial was basically on the one arm of the trial, we combined relacorilant with nab-paclitaxel, okay? And on the other arm of the trial, we just gave them nab-paclitaxel. The nab-paclitaxel was infused on a weekly basis, okay?
1 second, Dr. Olawaiye, just for our understanding, help us understand what the nab-paclitaxel is, so that, yeah.
So there are about, in popular use, there are 3 preparations of the taxane drug on the market.
Yes.
It's one of the most popular medications that are used in ovarian cancer. And so this group that we call taxane, it contains the paclitaxel molecule. That's the molecule in it. So in the most common formulation, that paclitaxel molecule is diluted in something called cremoform. So when you say Taxol, that's the one you are referring to.
Okay.
Okay?
Yes.
Now paclitaxel is the other one. It is packaged in albumin-like molecule particles. Okay. That is why we call it nab-paclitaxel. It's not diluted in cremoform. And there is a big difference between those two. If you use the one that is diluted in cremoform, okay, you have to pretreat the patient most of the time with steroid because the reaction rate to that formulation is high without steroid pretreatment. In fact, it's as high as close to 30%. And you reduce that by treating them with high-dose steroid before the therapy to about 3%. So that is what you have to do. But nab-paclitaxel, because it does not have cremophore, because that cremophore diluent is what most of the reaction is to. Yeah. So because you don't have that in nab-paclitaxel, you don't need to pre-treat the patient with high-dose steroid. Okay.
Thank you so much. Yes.
There is a third formulation which is also used. It's used in breast cancer. It's used in ovary cancer. It's called docetaxel. It's just another preparation of taxane. The reason we chose nab-paclitaxel is because of the need to avoid steroid therapy. Right. And when we talk about the mechanism of action more, that will become very obvious why that is important.
Okay. Please go ahead.
So the mechanism of action of relacorilant is, the main steroid floating around the body is called cortisol. Okay. To do its job, it has to attach to a receptor, okay, on the tissue. And that glucocorticoid receptor combined with a ligand, combined with cortisol, is how the effect of that combination happens.
Okay.
And that effect in ovary cancer is what we call glucocorticoid receptor signaling. What it does is actually activates, it does many things, but two most important things it does is activate two important genes.
Mm.
And one of those genes, people don't, of course, have to remember this, is called, serum glucocorticoid inducible kinase 1. Okay, SGK1 is one of the genes. The other one is called DOSP1, dual specific phosphatase. These genes are pro, um, pro-proliferation or anti-apoptotic genes. So what that means is that they help cancer cells to continue surviving and dividing.
Mm.
Okay. And in the specific case of ovary cancer, they do that by helping the cancer cells to be chemotherapy resistant.
Okay.
Once the genes are activated, the cancer cell tends not to respond to the chemotherapy that you give. And so what relacorilant does is a competitive antagonist of glucocorticoid receptor. So it goes in and binds to the receptor and prevents cortisol from binding to it.
Mm.
And when it binds to that receptor, it downregulates these two genes, the SGK1 and DOSP1. In this case, you can call them bad genes because they promote the cancer's resistance to chemotherapy. So when relacorilant binds, it downregulates them and therefore reverses the chemoresistance of the cancer cell. So your nab-paclitaxel that you give can then do its job and be able to kill the cancer cells because it is not so resistant anymore because of the relacorilant that is now on board.
Yeah. That's wonderful. And so from you talked about the two arms of the trial. And so one had only the NAB and the other had NAB plus the relacorilant, right? So what did you see? What was I mean, I'm so intrigued by this, so I'm just trying to dig a little deeper with you. Tell us what efficacy signals you saw, and that could be significant for the patient or the caregiver to know. And because if this is the first time anyone is hearing about this fantastic trial, I would want them to get as much information as possible. So.
You're not the only one that is intrigued, Ronsi. We're very intrigued too by what we found.
Yeah.
Because, first of all, think about it. Steroid is very generously used in patients that have been treated for cancer. So to go in and use this first-in-class drug, first time ever that this has been done, to block the steroid pathway and get the result that we got is very intriguing.
Yes.
Exciting, intriguing, something we're very happy about because if and when this gets approved, it represents another option for patients. And that is always exciting to any treating oncologists. Now, the other intriguing thing that we found about this, which I want to talk about first, why did we do the study the way we did it? Let me talk about that very easily because that is easy to understand.
Yes.
NAB toxins generally, okay, they are metabolized in the liver, okay? And what you will find on the trial is on the relacorilant arm, we use 80 milligrams per meter squared body surface area for the weekly infusion with relacorilant. And by the way, relacorilant is a pill. let me make that clear to your audience, because it's a pill that the patient uses, not even throughout the week. It's a pill that the patient uses the day before, the day of infusion of nab-paclitaxel, and the day after. That's it, only 3 times a week, which makes it very dose convenient.
Yes.
Okay. Now, when you look at the relacorilant arm, we had to reduce the dose of nab-paclitaxel, okay, because relacorilant is a powerful inhibitor of another enzyme in the liver that is called CYP3A4. That enzyme is the enzyme that is responsible for breaking down nab-paclitaxel.
Okay.
Okay.
Yeah.
And so when you inhibit that, it means that the availability of nab-paclitaxel is increased, right? Because you're not breaking it down. So if in our previous analysis, we actually saw that the tissue exposure, i.e. how much nab-paclitaxel is available to the tissue, is the same when you compare giving 80 milligrams with relacorilant versus giving 100 milligrams on its own. So the doses were equivalent. That is why that was done that way. The second thing that we saw, perhaps, so people who have read about this trial, who have thought about it, would say, well, it was not a placebo-controlled, right, trial. Yes, it could not be a placebo-controlled trial because of what I just explained, because the dose of nab-paclitaxel on the experimental arm, which is the relacorilant arm, was different from the dose of the nab-paclitaxel in the control arm. So that will make trying to make a placebo control difficult. But we mitigated against that by using what we call dual endpoints. Dual endpoints means we use progression-free survival by blinded independent central review, and then overall survival. And each of these would indicate positive trial if either of them became positive, and both of them, of course, were positive. The way we looked at this that was most intriguing to us, and we were very happy to see, was the toxicity. That is the part that was interesting, because there was no unique toxicity around that we saw with relacorilant. If you look at the trial, the toxicities that we saw, the bone marrow toxicity, nausea, neutropenia, neutropenic fever, all the side effects that we saw were the well-known side effects or adverse events that are known with nab-paclitaxel.
Okay. Now,
they were slightly worse on the side of relacorilant in the trial. But that is because the patients that were being treated on the side of relacorilant, they were doing well. And therefore, they were exposed for longer to nab-paclitaxel. And therefore, all you were seeing on the trial was that slightly worse toxicity because they got longer treatment with nab-paclitaxel. When we controlled for exposure length to nab-paclitaxel, the side effects that we saw on both arms of the trial were very comparable. In fact, I can give you the number. The people that were treated on the relacorilant arm of the trial were exposed to nab-paclitaxel 30% longer. And that accounted for the difference in toxicity. So this drug, with all the good things that it's doing, doesn't even have any unique toxicity.
That's wonderful. And because one of the big things that we always talk about, that whether the treatment may be very effective, but if there are if there is toxicity and if there are side effects that are so challenging that the patients cannot go through it, through the length of the treatment, then that is kind of self-defeating. So when you're saying that this one really doesn't have much side effects for the patients, or very tolerable side effects, that's really hopeful for us to know. So that's wonderful. Thank you. And so what kind of conversations should these patients begin to have with their providers in terms of the usability of this particular therapy if they were to be eligible for it? So anything else that you would like to share with us?
Absolutely. Hopeful. When we saw the result of this trial, we were all very excited, very happy to see the result. But what is that happiness originating from? For me and my colleagues who were involved in the trial is the fact that I have one other medication that I can use to help people. In fact, I'll tell you what I like to relate to people. One of my younger or junior faculties had called the research team here, had about 2 or 3 patients lined up to recruit to the ROSELLA trial, and came to me in my office because they told her that the trial had just closed. She was mad. She's like, why? Why can't I just get these patients on it? Because she had patients on the medication or already recruited into the trial. They were doing so well. And so she was like actively trying to. The ROSELLA trial, okay, recruited and closed many, many months ahead of projection.
That's
Yes.
wonderful.
And so that is how much people want to use it. Now, the company has been very magnanimous. And for the purposes of this interview, I would rather not mention the company, but you can look them up. Your doctor can apply to the company to have compassionate use of the medication prior to the decision of the FDA. Okay. That is allowed, and the company, because I have helped a couple of people apply, the company is prepared to let patients who want to benefit from this medication by letting them have it, like free of charge on compassionate ground.
That's wonderful to know, because this seems to be such a hopeful, another option for the patients. And if the company is allowing compassionate usage of the drugs even before the FDA approval comes through, then that is a very, very good path for the patients to talk to their physicians about the possibilities. So thank you for mentioning that. It's really helpful. So one quick question on, we have talked a lot about the ROSELLA trial. I'm going to switch to something else. But before I do that, I think you, from what I hear, you said platinum resistant and refractory if within the 2 months the cancer has come back. So technically resistant population. And so now in terms of all kinds of ovarian cancers, like whether it be germ cell or, low grade, high grade, all the types, how do you see all the types of ovarian cancers responding? Or is it just 1 or 2 particular types of ovarian cancers that you have worked as the basis of the trial?
The histological subtype of ovary cancer that is most common is high-grade serous.
Right.
Okay. And if you look at the general population of people being treated for ovary cancer diagnosis, 70% of them would have high-grade serous. Okay. Yes. We also allowed endometrioid group. I believe clear cell was also allowed. I think carcinosarcoma may have carcinosarcoma was allowed, but it has to be in a mixed histology type of situation. Okay. But honestly speaking, that was not an issue, because the majority of patients who are being treated for ovarian cancer have been treated for high-grade serous. So a lot of people, if not most people, would qualify, if they meet all the other inclusion criteria, would have qualified for the ROSELLA trial if they had used less than 3 lines of therapy. But let me quickly say something else, which obviously is in the future. It's when I came down the podium from presenting ROSELLA trial in 2025 June at ASCO, one of a European colleague pulled me to the side and said, "So, why are you limiting combination of these agents if the mechanism of action is what you described? It makes cancer cells susceptible to chemotherapy kill. Why can't you combine it with other things?" And I looked at him and said, "There's no reason not to. We just haven't done it yet
Yeah.
because it's a first in class." So in future, there are opportunities for this drug. Who is to say, I mean, the type of chemotherapy that we use for germ cell tumors, we give them generally a regimen called BEP regimen, bleomycin, etoposide, and cisplatin. And in future, who is to say we cannot try and combine that regimen with relacorilant? We just haven't gotten to the point of doing the study yet because you have to do a study in order to make sure that such a combination is safe to do. But if we work with nab-paclitaxel, if we can find a way to combine it with some other agent that we can avoid the use of steroid, because it doesn't make sense, right, for us to be giving high dose steroid when the drug we're going to give is going to be blocking steroid. That is why if that is not in play, then I don't see any reason why we cannot combine relacorilant with other agents. Right now, there is a study going on that is called the BELLA trial. In the BELLA trial, is a combination of nab-paclitaxel, relacorilant, and then with bevacizumab, Avastin. Those are the three drugs in BELLA trial. And if people have the opportunity to participate in the BELLA trial, that's another way to get opportunity to use relacorilant because it's a phase 2 trial, and therefore there is no randomization. If you get into the trial, you're going to get the three medications. You're going to get bevacizumab, relacorilant, and you're going to get nab-paclitaxel.
And thank you for breaking this down for us. You raised a very important point that this is the starting point of something really promising. That's not to say that this is where it's going to stay. It can have many other, like ways of using and indications in the future that you may be able to include. But this is a fantastic starting point for where you have started with the ROSELLA trial. So congratulations on all the fascinating and absolutely brilliant work that you and your team are doing. Just switching gears a little bit, Dr. Olawaiye, I know that you are also the vice chair of DEI in your institution. So, and you have cared for patients for decades. So tell us about the gaps and the disparities you observe in patient care, and how do you think we could overcome that so that every patient receives the kind of care that she deserves?
Thank you. That's so important, and a subject that is very dear to my heart. I mean, there cannot be anything wrong in everybody doing well, and that is what diversity and inclusion speaks to. Because when people do well, all of us should be happy that they're doing well. People that are diagnosed with any cancer they didn't do anything wrong. It just happened to them, and so why would we not want any particular group to do well? That's what makes us human, right? A human being is suffering, and you try to do your best to limit that because you think about them. It could be you, it could be me, and so it's very easy to see why it's so important for everybody to do well. Now, the number one thing that I would say that we have not been able to move the needle point by much is encouraging all populations of patients to participate equally in clinical trials. Now, that's a multifaceted problem, okay? For some people, it's access. They're just not in locations where clinical trials are popular or are available. That's one. Two, maybe they are close to such locations, but they don't have the means to travel to those places, which still speaks to access. Okay. Number three, they're not informed about the benefits of participating in clinical trials, which is extremely important. And number four, maybe they're actually in those locations. This is the part that is most concerning to me. And the clinical trial is not being offered to them, for some of these populations as it's being offered to other people. Okay. If you look at patients being treated for advanced cancer, and this is cancer of any type, solid malignancies, lung, whichever cancer, even liquid malignancies. If you divide them up and you look at those who, during the course of their disease, they participated on clinical trials, and then the other group, during the course of their disease, did not participate in clinical trials. The ones who did participate in clinical trials almost always live longer. And that is not surprising, right? Because the next breakthrough in therapy, remember, most clinical trials are designed, or their aim is to investigate how we can improve on what is currently the standard. And so whatever that thing is, call it X, is being studied somewhere right now. And if you're lucky to participate and receive X, you are actually benefiting 4 or 5 years before X becomes available on the market. So it's important to participate in clinical trial, and that would mitigate a lot of the disparity in cancer treatment outcome, because on clinical trials, there can be no bias. There isn't any room. If you're not administering the clinical trial protocol the way is specified in the books, you're violating the protocol. So that is so critical. I could not overemphasize that. The other side of that are just concerning things that you read about, and then some people will say, oh, well, there are, people just say these things, there's no evidence for them. No, there is evidence when you look very carefully, if you care. I mean, for instance, there was a big publication that looked at patients, women being treated for cervical cancer, right? Cervical cancer, initial treatment for those who are stages 1 and 1A and 1B, if the tumor is small volume tumor and so on and so forth, is surgery. And the reason why surgery is very good for that group is because you can treat the cancer surgically and avoid the side effect of treatment modalities like radiation and even chemo or immune therapy, which are all great treatments for the people that need them. But if you can just remove the cancer and the patient is cured, wouldn't that be great? And so for patients that fit that group, that we can do surgical extirpation and make the cancer go away, obviously surgery is the best treatment, right? There was this study that was published that looked at the chances of being offered surgery if you are in fact diagnosed with cervical cancer that is amenable to surgical resection. And it looked like if you're Black, you're less likely to be offered surgery. Yeah, that's most definitely not good. I think if somebody qualifies to be surgically operated on, whether they're Black, Asian, Native, whoever they are, it is the cancer that you want to treat, and your goal is for the patient to do well. Yes. You should offer that treatment to the patient. And I can give you so many evidence-based instances that show that there is discrimination without question. There was another study where they were looking at doctors being observed, seeing patients, and oblivious to the fact that our observation was going on, and that some of these doctors, when similar patients, being treated for similar conditions, cancer, when they enter a room that is occupied by a non-white person, they spend almost half the time in that room compared to the time they spend in the room that is occupied by a Caucasian. There is no way that is good, because whatever happens with the time the doctor is spending there, nobody is accusing the doctor of doing anything bad, but we all have to be aware of our internal biases and make sure that we teach ourselves not to let those biases. All of us, Ronsi, are biased. Bias is part of being human. That's part of growing up. I have my biases, you have yours. But I'm constantly trying to be aware of that so that my actions and dispositions are not affected by those biases. That's what we need to do.
And thank you for, sharing this reflection, because like you said, I mean, these are stark situations, and these are uncomfortable conversations, but if you don't have these conversations, then you cannot change the outcome. And like you said in the beginning, that we need to all take care of the person and the patient, and not the color or the gender or anything like that, because the humanity first. And that's what I truly believe in. And so I really admire the work that you do from the DEI space, because like you said, we have to be the voice of the patient, no matter where she comes from, no matter who she is and how she looks, right? I mean, because that's what human beings do, to lift one another. So thank you, Dr. Olawaiye. That was really candid, and I really appreciate that. So I know we are almost at the top of the hour, and I had more questions, but I don't know if I can go through them. But just generally, in your decades of experience, caring for patients, what have they taught you that you think the medical community like, what do you think the medical community and the patient community don't talk about enough, other than the topic that we just talked about? What is it that you have experienced?
Well, the reason why my life is very busy as a GYN oncologist. Some days of the week I operate all day. Some other day I have more patients in the clinic that I should have, such that patients are even taking pity on me, and patient will enter my office and go, "Are you going to see all those people out there?" Like, so they're even concerned for me. But here is the deal. Every single day when I finish doing whatever it is that I'm doing, whether it's research related, clinic patient. Today I was in a city called Altoona, which is about 2 to 2.5 hours out of Pittsburgh. I've been there for 2 days, operated all day yesterday, and saw patients all day today before I came to do this interview. I felt very fulfilled after that. Why? Because the bravery, the courage, the grace of the patients that you're treating for cancer. It is, well, in fact, let me tell you the way I think about them. I look at them and go, if I was in this woman's shoes, there's no way I can be that brave, but there's no way I can have that level of courage. Seeing those bravery and courage and their fierce graciousness in the face of difficulty, it gets me going. I look and learn from them every single day. And I think until the day I retire, I'm going to keep learning, because I just shake my head and go, wow, that is just a better human being than I am. I'm sure of it.
That's beautiful. Thank you so much, Dr. Olawaiye, for sharing that with us. And I know that I have asked you a lot of questions, but is there something that I missed asking you that you would like to share, whether it be science or anything related to the trials, anything that I may have missed that you would like to share?
Well, one thing that I like to quickly talk about before we part ways, Ronsi, first thing, thank you so much for giving me the opportunity to talk to your audience. I am very honored to be a new member or new friend of
Yes.
your group, and I'm happy to be invited back any day. But secondly, in the nearly 40 years, up to 2012, 2014, there were like 7, maybe less, drugs approved for ovary cancer treatment.
Yeah.
That was how scanty that treatment space was. Between 2014 and 2000, and maybe I should say 2000, and just say 10 years from 2013, just 10 years, there were close to 15 approvals, and we're still counting. So that is so exciting. And those of us who are in this space as care providers are so excited. I consider myself very privileged for me being an active practitioner in this time of evolution in ovary cancer treatment and the treatment of other malignancies. And I feel sorry for the people that practiced in the 80s and 90s when they were doing their best, but they didn't have all this great stuff that we have now. Then the second thing that I like to talk about briefly is what do I see in the near future? A lot. We've been talking all night about relacorilant and the potential that this may become available. That is extremely exciting. Okay. Hopefully that will happen soon. I also want to say that the Keynote B96 that I mentioned earlier it's pembrolizumab combined with Taxol and with bevacizumab. That's also a good combination. It hopefully will become available to patients because we want the options. Now, there is a group of drugs called antibody drug conjugates. Yes. And by the way, mavetoxumab soravtansine is one of them. But there is a host of clinical trials going on with these antibody drug conjugates. And some of them are so impressive that we can't wait for the trials to start reading out. They're already approved. Like I said, mavetoxumab soravtansine is approved. And there's another one that is already approved. They're in biomarker select groups, but the more of them we have, the better. There's a drug called trastuzumab deruxtecan for patients that have high-level expression of HER2. That drug just did so well in the Destiny Pantumor-2 trial in ovary, endometrial, cervical cancer patients that were in that trial. There were small numbers, but the response rate was very high. So, and there's I can mention about 15 of antibody drug conjugates that are in clinical trials right now. And we're hoping in the next 2 to 3 years, those trials will start reading out. And I think it's more exciting times in the near future.
That is so exciting. Yes, absolutely. Thank you so much for sharing. So much coming out in the next couple of years, it seems. And like you said, if you'd backtrack a few years, when my mom got diagnosed with ovarian cancer, this was, a few years, like 15 years ago, there was not much available. But now in comparison, there's so much hope for our community that makes me happy, like really, really happy. So in closing, Dr. Olawaiye, I always ask my episode guests, what message of overcoming would you like to share with all our overcomers and our listeners listening to you today?
Yes, the message that I want to share is that information availability basically has exploded. Yes. That is very powerful. That is great because you have access to almost any information on the World Wide Web. But I would caution listeners to us that they should be very cautious of information that they 100%. Just get from the World Wide Web, because negative information tends to be much more promoted and popular compared to positive information. So when you're being treated for these GYN malignancies, please don't give up. You have access to good things and just focus on trying to take advantage of those good things that you have access to. You don't have to be treated at one institution or the other. Just look at where things may be available for you and try to take advantage of them. I said it during my answer to one of your questions. Please consider participating in clinical trials. okay, for two reasons. It is overall very beneficial for anybody being treated for any of these cancers. Number two, whatever we're using for you today, some noble, gracious women a few years ago submitted themselves to clinical trials. That's how we got to the point where we can declare that this is the best drug for you. That is based on the participation of great patients who and their families who endeavored to help us with these clinical trials. And now we have those options available because of those women. And I know you're all noble, and I just want you to remember that in the course of getting treated.
Thank you so much, Dr. Olawaiye. That was a powerful message for our audience. And thank you for your time and all the hopeful work that you are doing to take us to this world without ovarian cancer. We cannot wait to see all the new things coming out in the next couple of years. And we hope to stay in touch with you as the ROSELLA evolves and to get to know more information. So thank you for your time and great chatting with you today. And overcomers, hope this information was beneficial for you. I hope you enjoyed the conversation and to be more informed and stay more empowered. And we will be back with the next episode of Connect Ovar Coffee. Until then, you keep inspiring and keep overcoming. Thank you and bye.
Thank you. Bye-bye.